Hi, my name is Vishal Gupta. I'm a radiation oncologist at Mount Sinai here in New York City. I have been part of the gynecologic cancer team for over 15 years, and today I'll be presenting an overview of gynecologic malignancies, clinical presentation, and treatment options. I have nothing to disclose and no financial conflicts. The objectives for today are to provide a brief introduction to radiation oncology, to recognize signs and symptoms of gynecologic malignancies, to become familiar with curative and palliative treatment options, and to understand the side effects of treatment and how to manage those side effects. To briefly describe different types of radiotherapy, teletherapy is the most common type of radiation modality used in the radiation oncology clinic. It is also referred to as external beam radiotherapy. Tele means distant in Greek, which means the radiation is coming from a distance outside the patient. This is typically performed with a linear accelerator machine. Every radiation oncology department in the country has one. This is a picture of the first linear accelerator ever developed at Stanford, about 1950s. And this is a picture of a more modern day linear accelerator. Another type of teletherapy or external beam radiotherapy machine is called a CyberKnife. This is a picture of that down here. This machine can rotate about on this arm. It's not typically used in gynecologic malignancies, but is often used in other parts of the body where it can deliver highly focal radiation treatments. Another type of external beam machine is called a gamma knife. It is used for brain tumors only, so we don't need to discuss its use today. And here's a picture of a gamma knife. It actually uses kind of a helmet that secures the patient in place while their brain tumors are treated. Another type of external beam radiation treatment is proton therapy. Proton therapy is probably available at 40 to 50 centers across the country. It is a very expensive technology that has been gaining more and more popularity. It is heavily advertised, so it may be something that you hear about. The benefit of proton therapy is that it has the ability to limit the amount of low dose radiation to non-target areas. For example, in this diagram here, the tumor is delineated in red. This is a brain tumor. The area of high dose is within this yellow circle. So you see a generous area that's being delivered by standard radiation. The limitation of the standard radiation of IMRT is that low dose of radiation is scattered throughout the rest of the brain. This is usually considered to be clinically insignificant, but may certainly have some cognitive effects later on, especially if this is given in children. Proton therapy, however, can deliver high doses of radiation to the tumor itself and does not have that low dose scattering to the remainder of the brain, so it can be advantageous in certain situations. Again, proton therapy is not used a whole lot in gynecologic cancers, but it is something that I was hoping you'd be familiar with. Another type of radiation modality is brachytherapy. Brachy means short in Greek, which means the radiation treatment, the radiation travels a short distance to get to its target. This is typically where we use a high dose of radiation to a very small area. There are two different types of brachytherapy. One is called intracavitary brachytherapy, where the radiation applicator is placed inside a cavity, such as the breast, in the lumpectomy cavity, or it can be used in cervix cancers or endometrial cancers. I'll be talking about the use of intracavitary brachytherapy in gynecologic malignancies more thoroughly later on in this talk. Another type of brachytherapy is interstitial brachytherapy, where radioactive needles or seeds are implanted directly into the target. The most classic example is prostate brachytherapy, where radioactive seeds are directly inserted into the prostate gland itself with the needle. Interstitial brachytherapy can be used in head and neck cancers, such as lip cancers. It can be used in sarcomas, breast, or vaginal cancers. Radiation treatment planning can involve multiple fields or beams to treat a specific area. In the most simple treatment, we can use one beam. This is an example of a spine metastasis with patient laying prone on their belly, and we have one field coming in posteriorly to treat that bone metastasis. This is about as simple as radiation planning can get, but typically radiation treatment involves multiple beams or multiple fields where each beam has a low dose of radiation, and the intersection of all of these beams results in a high dose of radiation at the target. So each beam, as it traverses through the body, will have a low dose, and so therefore causes minimal side effects, whereas the intersection of those beams results in a high dose to the tumor to hopefully eradicate it. Radiation dose is measured in a unit called Gray, abbreviated GY. Radiation treatments are usually once daily treatments as outpatient, and we typically give around 2 Gray per treatment. You'll notice I'll use the words treatment and fraction synonymously. We essentially have a total dose that we're trying to get to. That total dose is divided or fractionated up into smaller doses called fractions or treatments. The total dose of radiation depends on the goal and the setting of the radiation treatment. When we're treating microscopic disease, such as in a postoperative setting, such as in a lumpectomy situation where patients have the breast tumor removed, where we're treating microscopic disease, the total dose is 45 to 60 Gray. When we're treating macroscopic disease in a situation where a patient has not had any surgery, such as prostate cancer, we may need to treat up to 80 Gray. Patients receive 25 to 45 fractions or treatments over 5 to 9 weeks. In the palliative setting, the doses range from 8 to about 45 Gray. This can be done a span of 1 day to over 5 weeks. Typically, however, palliative radiation occurs over 2 weeks, but there are certainly different options depending on the setting. We work closely with physicists and dosimeters to calculate the radiation and determine the angles of the fields. I'll now discuss the management of endometrial cancer. Endometrial cancer is the most common gynecologic malignancy in the United States. There are approximately 60,000 cases diagnosed annually, with about 10,000 deaths. Patients typically present with postmenopausal bleeding. Patients may also present with pelvic pain. In more advanced cases, patients may present with shortness of breath if they have lung metastases. The treatment for endometrial cancer begins with surgery. That is the first step in this disease. Chemotherapy and/or radiotherapy may be needed after surgery, depending on the findings at surgery and the pathology reports. Case number 1. This is a 75-year-old female that presents with vaginal bleeding. She has a transvaginal ultrasound that shows a thickened endometrial stripe. The patient has an in-office endometrial biopsy that confirms endometrioid adenocarcinoma. The gynecologic oncologist performs a total hysterectomy, bilateral salpingo-oophorectomy, and lymph node dissection. The pathology shows a grade 1 tumor that is stage 1A. There's no lymphovascular invasion, and there are no involved lymph nodes. Postoperative treatment, this patient does not require any. The chance of her recurring with such a low-risk tumor is very low, therefore no adjuvant treatment is recommended. Here's a reference for that recommendation. So I wanted to provide an overview of hysterectomies. There are 5 types of hysterectomies based on the extent of the surgery. Type 1 hysterectomy is the least aggressive surgery. It typically removes only the cervix and uterus. It is often combined with a bilateral salpingo-oophorectomy, where the ovaries and fallopian tubes are often removed as well. This is the most common type of surgery performed for endometrial cancer. The most aggressive type of hysterectomy is a type 5 hysterectomy, also called a total exoneration. This is where not only are the uterus and cervix removed, but the vagina, bladder, and rectum as well. And that will obviously require a colostomy and urinary diversion. Type 5 hysterectomies are not commonly performed for GYN cancers, but type 1, as I mentioned, is the most common for endometrial cancer. Here is a diagram of that type of surgery for a type 1, where the cervix and the uterus are removed, and typically it's with a bilateral salpingo-oophorectomy with the fallopian tubes and ovaries removed as well. A type 3 hysterectomy is somewhat intermediate in aggressiveness between the type 1 and type 5. You'll see the ovaries, fallopian tubes, uterus, and cervix are removed, but there is a little bit more vagina that is removed with a type 3 hysterectomy, as well as this tissue next to the uterus and cervix called the perimetrium that is also removed. A type 3 radical hysterectomy is the typical hysterectomy performed for cervix cancer, whereas for endometrial cancer, a type 1 hysterectomy is most common. The potential side effects of hysterectomy and their treatments are listed here. Pelvic pain are often treated with opioids and NSAIDs. Ileus may result, and the management is with bowel rest. Urinary retention may require Foley catheter. Wound complications, nerve damage such as lateral thigh numbness or leg weakness may necessitate physical therapy. Patients are often resulting in surgical menopause if they're not already postmenopausal, and lymphedema may require compression stockings or physical therapy. Case 1A, there's a slight twist in this one. Again, a 75-year-old female with vaginal bleeding. The surgeon performs the typical surgery. Pathology, however, in this case, there is a grade 1 tumor with cervical stroma involvement. Lymph nodes are negative. This is considered a stage 2 cancer because it is involving the cervical stroma. The postoperative treatment in this case is typically external beam radiotherapy and brachytherapy to the vaginal cuff with a vaginal cylinder. So in summary, radiation is used in some stage 1 cancers and most stage 2 cancers. And here are some references to back up that recommendation. So the radiation treatments I was describing that would be used in this example would be a combination of external beam and brachytherapy. The external beam radiotherapy treats a larger area to essentially a medium dose. So it treats the vaginal cuff. The vaginal cuff is what is resultant after the surgeon removes the cervix and the uterus. They stitch the vagina closed, and this results in a vaginal cuff. So that is at risk. And so the external beam radiotherapy treats the vaginal cuff. It treats the residual perimetrium, since that was not removed in a type 1 hysterectomy, and it treats the pelvic lymph nodes. The surgeons are able to remove a sample of the pelvic lymph nodes, but they certainly do not remove all of them. So the remaining pelvic lymph nodes are also targets in this external beam treatment. As I mentioned before, external beam is typically given daily, and it is Monday through Friday for 5 weeks. So we typically give 45 gray with 1.8 gray per day. For a stage 2 case, we would also add brachytherapy via a vaginal cylinder. This would be completed after the external beam is completed over 5 weeks. So with the cylinder, we treat the vaginal cuff only. This allows us to give a high dose of radiation to the vaginal cuff. It does not treat the perimetrium or the pelvic lymph nodes. The vaginal cuff is the most common site of recurrence in early stage disease, and because of that, we kind of give this an extra dose, what's called a boost. So on top of the 45 gray that the vaginal cuff receives with external beam, we deliver an additional 15 gray over 3 weeks. Each treatment, it's given weekly. So that's 5 gray per day. That's given for these 3 treatments, and it allows us to give an extra dose to the vaginal cuff to make sure that any microscopic disease that is still residual after surgery is eradicated. Here's 2 different diagrams of the radiation doses in external beam, which is on the left, and brachytherapy, which is on the right. You can see the full dose of external beam outlined here in red. It treats the vaginal cuff, which sits in this area. It also treats the pelvic lymph nodes that sit along the pelvic bones. You can see unnecessarily it's treating some of the bowel and the rectum. It's a very generous area to treat a big, it's a generous field to treat a big area when we're treating multiple sites at once. We do have some fancier radiation techniques that can minimize dose to the bowel and the rectum, but I just wanted to provide this slide as an overview. You can see the low dose of radiation, this 50% line, saying that half of the dose goes to essentially to the perimeter of the body. This is usually considered of little clinical significance, but I just wanted to demonstrate how diffuse of an area this is treating. When we use brachytherapy, the This is the cylinder in the vagina. This is the bladder, and this is the rectum posteriorly. You can see that the full dose is really just targeting the cylinder that's in the vagina and the vaginal mucosa, whereas the full dose goes out to the pelvic bones here. The full dose is really just limited to the vagina here. And then you can see the 50% dose is really just limited to a portion of the bladder and the rectum, whereas the 50% includes, the entire kind of pelvic or abdominal content. It's a much more generous area. So the brachytherapy is a much more targeted way to deliver radiation, and it is very effective when we're treating just a small volume. However, there are certain situations where we may need to target a bigger area, and therefore we sometimes use a combination of external beam and brachytherapy. I did not provide any examples where there was a stage 1 tumor that may require brachytherapy only, but there are certain situations where stage 1 patients may require brachytherapy only just to treat the vaginal cuff, where the patient does not have a high risk of lymph node involvement or perimetrial involvement. So we can sometimes use external beam alone or brachytherapy alone, or sometimes we combine them depending on the clinical scenario. Possible side effects of external beam radiotherapy are divided into acute, which means that these side effects develop during or shortly after radiation, and then chronic side effects are those that may persist or develop months after radiation. Acute side effects that may develop during or after radiation include diarrhea or rectal bleeding, and you can see there are a few different management options, including loperamide, Lamodal, and steroids. Patients may develop urinary frequency and urgency. They may have dysuria and hematuria. They may develop skin desquamation, especially in skin folds in obese patients. Patients may develop nausea and vomiting where antiemetics are needed, and patients may develop fatigue. These side effects, if they develop, typically resolve within 2 or 3 weeks of completing radiation. However, some may persist and develop into chronic side effects. So patients may continue to have diarrhea or rectal bleeding that may require colonoscopy with coagulation. Patients may have persistent urinary frequency and urgency. They may have urine or fecal incontinence, however, that is extremely rare. They may develop bowel obstruction or perforation. They may develop leg edema that may require compression stockings and or physical therapy. I will say leg edema is quite rare these days, since that used to be resultant when surgeons performed more extensive lymph node dissections, but since they're not performing such extensive lymph node dissections, we rarely see leg edema these days. Patients may also develop femoral neck or pelvic bone fractures years after going through radiation therapy. Those are managed with physical therapy, potentially oral pain medication. Possible side effects of cylinder brachytherapy. Acutely, patients may develop diarrhea or dysuria, but if you remember the slides where I showed the radiation doses to adjacent structures from brachytherapy, it's a minimal dose to the adjacent structure. So usually patients do not have much side effects from brachytherapy. Chronically, patients may develop vaginal dryness or vaginal fibrosis or scarring. We recommend patients use vaginal dilators to prevent these complications from occurring. And we also have pelvic floor physical therapy. Unfortunately, not many institutions provide physical therapy for these indications, but there are typically some major cancer centers that do provide it. So I highly recommend it if patients develop significant scarring. Patients may develop urethral stricture or fistulas. That would be a vesicovaginal or rectovaginal fistula from brachytherapy. Extremely rare, but possible. Case 1B, this would be a 75-year-old, again, presenting with vaginal bleeding, has the recommended surgery. Pathology this time reveals a much more aggressive cancer. It's a grade 3 tumor involving multiple lymph nodes, including periaortic lymph nodes. This patient would be considered to have stage 3C2 disease because of periaortic lymph node involvement. Postoperative treatment includes chemotherapy. It's typically carboplatin and paclitaxel for 6 cycles. Here's a reference for that recommendation. Patients are now being offered immunotherapy in this setting as well. It's kind of a hot topic, which I didn't really include in this because it's perhaps outside the scope of this talk. But do know that immunotherapy is being considered in these patients. Carboplatin and paclitaxel are typically given every 3 weeks for 6 cycles via IV infusion. Possible side effects of this chemo regimen include neuropathy, physical therapy, and medication may help. Patients experience alopecia, nausea, fatigue, cytopenia, and anorexia. You can see some management options for those side effects as well. Overall survival by stage for endometrial cancer are listed there. I'll now move on to the management of cervix cancer. Cervix cancer is the most common gynecologic malignancy in the world. About 500,000 cases are seen annually worldwide. The US does not see as nearly as many cervix cancers as endometrial cancer. There's only about 12,000 cervix cancers in the country a year. Worldwide, there are about 250,000 deaths from cervix cancer. In the US, only approximately 4,000. The presentation of cervix cancer typically includes vaginal bleeding or discharge. Patients may have pelvic pain, especially after intercourse, and cervix cancers can be detected on abnormal pap smears. The treatment for cervix cancer, early stage cervix cancer is typically treated with a type 3 radical hysterectomy, as I showed you earlier in the diagram before. Patients who have hysterectomy may require external beam radiotherapy. Afterwards, the external beam may be accompanied by concurrent chemotherapy as well. Patients who have intermediate to late stage cervix cancer are treated with chemoradiation. There's no role for surgery in these more advanced stage patients. Case number 2 is a 65-year-old female with postcoital pain. She sees her general gynecologist, who notes a 5-centimeter friable lesion on the cervix at 3 o'clock. A pap smear is performed, and squamous cell carcinoma is detected that is HPV-16 positive. She has a PET scan to determine the extent of disease, and it shows FDG avidity in the cervix, but no lesions anywhere else. This is stage 1B3 based on the size of the tumor being more than 4 centimeters. The treatment for a 1B3 tumor is typically concurrent chemoradiation. This is based on a couple of different studies that were published many years ago. The radiotherapy techniques we use for definitive cervix cancer include external beam radiotherapy. In this situation, the cervix and uterus are intact, so the external beam treats the cervix, the uterus, the perimetrium, and the pelvic lymph nodes. Patients are treated daily, Monday through Friday, over 5 weeks. Patients receive 45 gray and 25 treatments at 1.8 gray per treatment. Patients are also treated with intracavitary brachytherapy. The applicators we use in this situation are either tandem and ring or tandem and ovoids. They're essentially the same treatments. It's just some institutions have different devices. At my institution, we use tandem and ovoids, but both are available. Brachytherapy will treat only the cervix and uterus. It does not treat the perimetrium and does not treat the pelvic lymph nodes. Because the patient in this example had a 1B3 tumor that was 5 centimeters, she has a significant risk of perimetrial and pelvic lymph node involvement. So we need to give those a medium dose of 45 gray. But we know the cervix has cancer, and so we need to give the cervix and the lower uterus a higher dose. And so we treat with a brachytherapy boost with these applicators. Brachytherapy, this type of treatment is often given weekly for 4 weeks. So we give 7 gray per treatment. So they're given a total of 28 gray in addition to the 45 gray. In cervix cancer, we almost never give brachytherapy alone. It is usually accompanied with external beam radiotherapy. So patients typically get both external beam and brachytherapy. The possible side effects of tandem ring or tandem ovoid brachytherapy are divided again into acute and chronic side effects. Acutely, patients may develop diarrhea and pain on urination. The applicators themselves may result in uterine perforation, which means that the tandem can poke through the uterus. Sometimes it is difficult to figure out exactly where to put this tandem when you're going through the cervical os. That cervical os may be covered with cancer, and so you may not be able to find this opening. And so sometimes it can be a little bit of a guessing game where we insert this. This is often done in the operating room under anesthesia. I often go with the surgeon so we can both work together to find where the cervical os is. This tandem can go in the wrong direction, as I mentioned, cause uterine perforation. The vagina can also develop tears from the applicators stretching the vagina too much. These can happen and can result in bleeding and may require suturing. Chronically, tandem ring brachytherapy often results in vaginal dryness, fibrosis, and shortening. Again, we recommend vaginal dilators to prevent this from happening and often refer our patients for pelvic floor physical therapy. Patients may develop a stricture of the urethra, and they may develop rectovaginal or vesicovaginal fistulas. External beam to the pelvis. I already mentioned the side effects in the previous section of endometrial cancer, but I wanted to mention that because patients with locally advanced cervix cancer typically have intact ovaries and uterus, the external beam results in ovarian failure and makes the uterus unable to carry a fetus. So these patients may develop osteoporosis from the lack of estrogen, so hormone replacement therapy may be recommended. They can develop hot flashes from menopause, and we often refer our younger patients for fertility counseling. The typical chemotherapy that's administered with radiotherapy for cervix cancer is cisplatin. It's given weekly with external beam radiotherapy. Possible side effects of cisplatin are nausea, cytopenia, neuropathy, ototoxicity, nephrotoxicity, and low magnesium and potassium. You can see management options listed next to those side effects. I would also like to mention that immunotherapy is also being added to cisplatin in select cases, but again, that is outside the topic, outside of the scope of this lecture. Listed here is the overall survival by stage for cervix cancer. I'll next discuss the management of ovarian cancer. Ovarian cancer is seen in about 22,000 cases annually, with about 14,000 deaths. Patients often present with peritoneal spread, and they report bloating and increased abdominal girth. They may have abdominal pain or pelvic pain. They may have abnormal bowel and urination. Treatment typically involves surgery and chemotherapy. The chemotherapy regimen used is carboplatin and paclitaxel. The surgery typically involves bilateral salpingo-oophorectomy, hysterectomy, lymph node dissection, and omentectomy. As I mentioned before, carboplatin and paclitaxel is the typical chemotherapy regimen. It may be given IV or intraperitoneal. Young women with low-grade tumors in a unilateral ovary may have a unilateral oophorectomy for fertility preservation and without chemotherapy. Advanced cancers may require tumor debulking, including a bowel resection with colostomy. Side effects of ovarian cancer treatment: surgical menopause that may result in hot flashes and osteoporosis. Patients who undergo bowel resection will need a colostomy, and intraperitoneal chemo may result in abdominal pain and severe nausea and vomiting. Listed here is the overall survival by stage for ovarian cancer. I'll now move on to the management of vulvar cancer. Vulvar cancer is quite rare. Only about 5,000 cases are seen annually in the US, with about 1,000 deaths. Patients may present with a vulvar mass or pruritus. They can have pelvic pain, bleeding, dysuria, hematuria, or in more advanced cases, they may present with a growing mass due to an enlarged lymph node. Treatment typically involves surgery with radiation to follow. For select cases, more advanced cancers may not be candidates for surgery and may have definitive chemoradiation instead. The surgery typically involves a wide local excision a modified radical vulvectomy with lymph node dissection. Depending on the laterality of the primary tumor, the lymph node dissection may be either unilateral or bilateral. If the tumor is in the midline, it typically requires a bilateral lymph node dissection. However, if the tumor is well lateralized, perhaps an ipsilateral an ipsilateral dissection alone is sufficient. Patients who have lesions that are close to the urethra, clitoris, or rectum may not be eligible or may decline surgery. These tumors in these locations it's difficult to get negative margins, and they may require exoneration. So patients may be recommended for chemoradiation instead. Surgical complications for vulvectomies include wound infections. This area is particularly prone to wound infections given the skin folds in this area. Patients can develop lymphedema, especially if they have an aggressive lymph node dissection. Patients can have sexual dysfunction, especially if they receive postoperative radiotherapy. The introitus may be scarred down, and it may be difficult for penetration. Patients can develop thrombosis. These patients are often on bed rest after surgeries, especially if they have an aggressive lymph node dissection. They may not be able to move very much because of the surgical wounds in their groin. And if they're on bed rest, they're more likely to develop blood clots. And then patients who require exoneration may need urinary diversion and colostomy. The radiation treatment may result in significant toxicity for vulvar cancer. The vulva is one of the most sensitive areas for radiotherapy. Acutely, the patients can develop significant skin desquamation with superinfection. We recommend sitz baths, Dombro solutions, and antifungals to help manage this. Patients can develop severe diarrhea and frequent urination, which can further irritate the skin. Patients have cystitis, so just a pain on urination, and they may lose pubic hair. Chronically, they can develop atrophy and telangiectasia of the skin. The vagina can become dry, fibrotic, and short. Patients can develop femoral neck fractures, femoral head necrosis, pelvic bone fractures, and these risks are increased if the patient is a smoker or has baseline osteoporosis. Listed here are the overall survival rates by stage for vulvar cancer. Next, I will discuss the palliative treatment options for gynecologic cancers in general. The cases that may require palliation in gynecologic cancer include pelvic pain, vaginal bleeding, urethral, rectal, or bowel obstruction, or fistulas such as vesicovaginal or rectovaginal fistula. Pelvic pain can be managed with pain medicine, occasionally palliative surgery where the painful tumor is removed. Chemotherapy or radiation may be used to shrink tumor to alleviate pain. Vaginal bleeding can be managed with vaginal packing, Monsell solution, or silver nitrate. Palliative surgery may be recommended. Again, chemo and or radiation can shrink tumors and stop bleeding. Embolization may be utilized. This is where an artery or a vessel is blocked so that the blood flow does not result in bleeding. And this is typically performed by interventional radiology. In patients who have urethral, rectal, or bowel obstruction, palliative surgery may be required to remove the tumor. This may necessitate a diverting ostomy or feeding tube. An NG tube and bowel rest may be used for bowel obstruction. Foley or suprapubic catheter may be needed for urethral obstruction. And again, chemotherapy and or radiation can be used to shrink the tumor to relieve the obstruction. Palliative radiation treatment, a typical regimen is 30 gray that's delivered over 2 weeks. However, other regimens are possible, such as 20 to 25 gray in 1 week, 45 to 50 gray over 4 to 5 weeks may provide a more durable response. Or in urgent bleeding or pain cases, 8 gray can be given in 1 day. It's not commonly used for large masses, but it is an option depending on the clinical situation. Another regimen that can be used is 3.7 gray given twice daily, once in the morning, once in the afternoon. This can be given 2 days in a row, every 3 weeks for 3 cycles. This is a great option for inpatients and those that are hospice bound. So we occasionally will use this regimen. Radiation is about 90% effective in controlling bleeding, and the bleeding typically stops within 1 week from the start of radiation. Radiation is about 65% effective in controlling pain within 2 or 3 weeks of the treatment. 1/3 of patients have a complete response to pain, 1/3 of patients have a partial response, and then 1/3 of patients have no response. That is the conclusion of my talk. If you have any questions, please feel free to contact me at this email address. I appreciate your time and attention. Thank you.